So my greetings to all of you, and I'm not able to participate physically due to some exigency. So my apologies to Dr. Prateek. And today I am speaking on new kid on the block, the central quadriceps tendon graft. Actually, why we are calling it as a new kid? If we look at the literature, it's no more a new kid. Is it a really new kid, or it has been ignored the wisest oldie? Actually, the central quadriceps tendon graft was first used in 1979 by Marshall and later on successfully used by Bloch in 1984. 1990s onwards, there are many studies which have reported good results with this graft. And if we look at the literature, every 5 to 10 years, this graft has been revisited in the, although it was introduced in late 1970s. Now, if we look at the graft of choice for ACL reconstruction, still it is a controversy. This is, even today, the age-old bone patellar tendon bone graft is still considered as the gold standard, and all the other grafts are compared with the results of BPTB. Although it has its own pitfalls like anterior knee pain, risk of patellar fracture while harvesting, and future risk of osteoarthrosis of the knee joint. This is one of our own papers published in 2020, which has also given similar results that BPTB is still the gold standard. But at that time, we compared our results with the free hamstring graft, and later on, we started using the hamstring graft with preserved insertion. When we compared our results of BPTB with semitendinosus and gracilis graft with preserved insertions, there was no difference in the outcome. But still, I would say that the gold standard is BPTB. Now, these are the evidence-based clinical practice guidelines issued by American Academy of Orthopedic Surgeons just recently in the year 2022, which say that amongst the autograft and allograft, autograft is the graft of choice, and between all the grafts in skeletally mature patients, the graft of choice should be the bone patellar tendon bone graft. Now, the quadriceps tendon graft is the least studied graft throughout the years in the literature, and it is, of course, least used also. The literature says it is being used by 1 to 11% of the surgeons globally. It has been seen in various kind of surveys done in the various meetings that it is used only somewhere in 1% surgeons and somewhere maximum up to 11%. Now, the anatomy of quadriceps tendon, we must know if we want to use this graft. We know that it is by the confluence of three tendons, rectus femoris, and a conjoined tendon of vastus lateralis and medialis, and the deepest one is vastus intermedius. The graft is strong enough, and usually 8 to 10 centimeters of the graft can be harvested in length, and around 6 to 7 millimeters graft can be harvested in depth, and around 10 millimeters can be harvested in width. So this is the highest dimensions amongst all the grafts. So as I mentioned, 8 to 10 millimeters long. Although the depth of the tendon is 10 to 12 millimeters, but if you harvest partial, so you go 6 to 7 millimeters deep. Now, there are a number of studies and meta-analysis which has established that this graft has the equivalent or better results than the other grafts. This is 2022 American Journal of Sports Medicine, Vanil et al. They have established that the quadriceps tendon autograft had comparable graft survival, functional outcomes, and stability outcomes as compared with the BPTB and hamstring graft. However, the donor site morbidity in quadriceps tendon graft was less as compared to the other two grafts. Another study in 2021 gave similar results. And this is another meta-analysis in 2019, the American Journal of Sports Medicine says the results were comparable clinically, functionally, and outcome of the graft survival was similar with lesser anterior knee pain as compared to BPTB, and it was better in functional score as compared to the hamstring graft. Now, this is another systematic review by Harris et al. Again, the use of quadriceps tendon graft has been observed to be supported by the current orthopedic literature. It is safe, reproducible, and versatile graft. Journal of ESACOS in 2022, again, the quadriceps tendon has a lower re-rupture rate than the hamstring graft and lower donor side morbidity. It was better for residual pivot shift, but there was no difference in the patient-reported outcomes. Now, why we call it the kid in the block? Because it is gaining popularity recently due to the shortcomings with the other grafts. So still it is a kid amongst the larger population of surgeons. If we use a proper technique, one can use a longer, wider, and a graft with a higher tensile strength, and the graft has approximately 50% more mass than the BPTB tendon. Now, whether you use the graft with a bone block or patella or soft tissues, both can be used, and the studies show that there is no difference in the clinical outcomes and subjective stability or failure rates. But with a bone block, we have the advantage of faster bone-to-bone healing in the tunnel. Also, when we use the quadriceps tendon with bone block, it is more useful in revision ACL reconstruction because there is usually enlarged tunnels, and a 10 mm bony block can help us for filling that large tunnel. Now, the other thing is whether you use a partial thickness or full thickness quadriceps tendon graft. Both can be used. There is no difference in clinical outcome or complications, and there is no difference in residual quadriceps strength. Now, as far as the technique is concerned, we give a small incision just proximal to the patella, identify the quadriceps tendon, mark 10 millimeters width of the tendon just proximal to the patella. If you want to harvest the patellar bone, mark the same width on the patellar bone also. Saw the patellar bone approximately 6 millimeters in depth, and then you separate the bony plug with a small osteotome, and then by using a sharp dissection, you dissect the 10 mm wide quadriceps tendon graft, either partial graft or full thickness graft. You can close the defect with a absorbable 2-0 vitral suture later on. So these are our own pictures. Here is the skin incision, and then actually I use this paper scale. I cut 10 millimeters of it and then place it on the quadriceps tendon, mark on both the sides of the scale, and then mark on the patella also. Then you saw the patella on both the sides like here, and then harvest the patellar bone with the osteotome, and finally you can, this is the video. It shows that the graft can be harvested like this. The skin incision, the cutting of the paper scale, the placing of the paper scale on the quadriceps tendon and marking the patella as well as the tendon. And then you saw the patella bone on all around. And then after separating the bony plug from the patella, you hold it with an instrument, and with sharp dissection, you harvest the graft as a parallel 10 millimeter incisions on both the sides, which was marked by you earlier. So you can go up to around 7 to 8 centimeters proximally. And if you really are using a partial thickness graft, then don't go deep to the rectus femoris tendon. Usually there is a fatty layer between the rectus femoris and the vastus interna. So finally, you prepare the graft on the back table like the other grafts. So that's all about how you harvest it. And in summary, the central quadriceps tendon is an age-old graft. It is very, very reliable graft. If you look at the various studies, it is stronger than almost all the other grafts. It was often forgotten, probably because it is, slightly difficult to harvest. But whenever the surgeons, they are in dire need because of the shortage of the grafts, especially in multiple ligamentous injuries, then they remember this graft. It has comparable results to any other graft. There is minimal donor side morbidity as compared to the other grafts. Of course, as I mentioned, technically it is a bit more demanding. But if you start using it, you may master this technique and you may really do a good job. So thank you very much for your patient listening. Thank you.